This conference will now
Hello.
be recorded.
Hello. Okay. Just,
Hello, ma'am. Good evening.
yeah, good evening. All right. Okay, so today we would be covering the important points in the module early pregnancy. All right. So for as far as the part two MRCOG exam is concerned, there are certain topics that would be important for you to know thoroughly in this particular module. And the reading material is not quite extensive for early pregnancy module as such. There are very few guidelines and yes, a little bit of certain talk articles like the cesarean scar pregnancy, and then there is RCOG e-learning. And otherwise, you have your green top guideline on diagnosis and management of ectopic pregnancy and miscarriage, the management of gestational trophoblastic disease, recurrent miscarriage, management of nausea and vomiting, ectopic pregnancy miscarriage NICE guidelines, and the abortion care. So we would be looking at what's really, really important for us as far as the exam is concerned, and some important concepts would be covered today. So first, let's look at the guideline on the diagnosis and management of ectopic pregnancy and miscarriage, as well as the NICE guidelines on ectopic pregnancy and miscarriage. A few figures that you would need to know. So this is an important figure here. In the UK, the incidence is around 11 in 1,000 pregnancies, and with an estimated of 11,000 ectopic pregnancies diagnosed each year. So the incidence is 11 in 1,000 pregnancies. The incidence of ectopic pregnancy in women attending early pregnancy unit is slightly higher. Now, remember, this is for all the pregnancies, and this is those who are attending early pregnancy unit, which is 2 to 3%. And as far as the RCOG e-learning is concerned, the death rates have unfortunately risen in the UK, and with 8 women dying between. Okay, you cannot see the slide. Is that what you? 1 minute. Let me just share it once again. I had shared the screen. I'm not quite sure. Okay, are you able to see now?
Yes, ma'am. It is okay now.
All right. Okay. So what we are doing right now is the NICE guideline and the Green Top guideline on ectopic pregnancy. So we just to recap, so the incidence in the UK is 11 in 1,000 pregnancies for ectopic pregnancies diagnosed each year. For those attending early pregnancy unit, the incidence is higher, so 2 to 3%. And as far as RCOG e-learning data is concerned, there is an increased number of women dying, 8 women dying between 2018 and 2020 because of an ectopic pregnancy, compared to 5 between 2015 to 17. So that is why it becomes a very important topic for us to know, particularly in the early pregnancy module. It is a short question in the exam. You may need to know a few common symptoms of ectopic pregnancy, because what you could expect in the exam is a clinical situation, a clinical scenario, and you would need to diagnose or pick out from the options the investigation like beta HCG, etc. So the common symptoms would be abdominal or pelvic pain, amenorrhea, whenever there is amenorrhea, please have a suspicion of ectopic pregnancy. Vaginal bleeding with or without clots. Other reported symptoms are symptoms related to pregnancy as such, like breast tenderness. GI symptoms also may be there. Always check if the lady under concern is in reproductive age group. Okay, so if there are unusual symptoms, amenorrhea, please ask for pregnancy test. So urinary symptoms, syncope, dizziness, shoulder tip pain, rectal pressure or pain on defecation, passage of tissue. And pelvic tenderness, adnexal tenderness, and abdominal tenderness are the signs that we can elicit as far as the ectopic pregnancy is concerned. These are also other signs of ectopic pregnancy, including rebound tenderness or peritoneal signs. So watch out for such signs which may be mentioned in the question, which is important for you to consider a diagnosis of ectopic pregnancy. So what we must remember is whenever there is a woman who's come to you belonging to the reproductive age, particularly with non-specific complaints, always offer a pregnancy test, always. So that would be the option that you would choose in case you see that there is a situation, a clinical scenario mentioned that says that there is a lady in reproductive age group who comes to you with non-specific complaints like sudden diarrhea or even a lower abdominal pain, urinary complaints. It could be even bowel bladder disturbances that she comes with. Ask for amenorrhea and do a pregnancy test, offer a pregnancy test rather. Now, this is mentioned in the RCOG e-learning whether a negative pregnancy test excludes an ectopic pregnancy. For the practical purpose, yes, it does, but there have been cases wherein even a negative pregnancy test is associated with an ectopic pregnancy. How do we explain this? Maybe it is a chronic ectopic wherein the trophoblastic tissue has died away, but there is some amount of bleeding. So in such a situation, you can have a negative test, but remember, it is not common. And but this was mentioned in the RCOG e-learning, so you may consider ectopic as one of the differentials, even if the pregnancy test is negative. So, a lady who comes with bleeding and other signs and symptoms of pregnancy and who have pain, a pregnancy of 6 weeks gestation or more, a pregnancy of uncertain gestation would need to be referred to an early pregnancy assessment unit. That's important. Okay. So, a patient who is stable would need to be referred to an early pregnancy assessment unit. While if the patient is unstable, then the first thing that would be done would be a fast scan. Okay, that is, you need to do a scan to check if there is any fluid in the free fluid in the tummy or any evidence of ectopic pregnancy. The scan is called FAST, the fast scan. Okay, the diagnosis. Now, this is important for us to know. As far as the tubal ectopic pregnancy is concerned, remember the tubal ectopic pregnancy is the commonest of all the ectopic pregnancies. So that is 98%. So 98% of all ectopic pregnancies would be your tubal ectopic. Okay. So 98%. Sorry. Yeah. Of which 5% would be in the femoria, 80% would be in the ampulla because that is where the fertilization occurs and that is a bigger space for the pregnancy to implant. So 80% of the cases, the implantation would occur in the ampulla. 12% would be in the isthmus and the others would be in the interstitial part of the tube. So 98% of all ectopic pregnancies would be in the tube. So that is the commonest presentation and the commonest question that is asked. The diagnostic tool that is used for ectopic pregnancy would be a transvaginal ultrasound, and it has a relatively high sensitivity and specificity. All right. So now this is very important for us to understand. Remember, for us to know that there is an ectopic pregnancy for sure, you need to have, you need to see on ultrasound the uterus with the endometrial cavity, which may be a little thickened because of the pregnancy changes, the hormonal changes associated with pregnancy. At the same time, you should be able to see the tubes and the ovaries. In 50 to 60% of the cases, that is majority of the cases of ectopic tubal ectopic pregnancy, what you can see is an inhomogeneous or non-cystic adnexal mass. That means you can see something like this. This is in 50 to 60% of the cases, majority. Sometimes you can see an extrauterine gestational sac like this. This is an extrauterine gestational sac. It appears like a tubal ring. It's a tubal ring sign. It's like a sac inside the tube. An extrauterine gestational sac containing a yolk sac or an embryonic pole may be seen in 15 to 20% of the cases. So this thing that you can see here sometimes may appear as a gestational sac with a yolk sac, or there may be a baby there. Now this, what you see, is considered as a definitive sign of pregnancy. So whenever there is yolk sac, that is considered as a definitive sign of pregnancy. So if there is no yolk sac, in most of the cases, you see such an inhomogeneous mass, which would raise the suspicion of pregnancy, but it is an ectopic pregnancy, but it is not a confirmed ectopic pregnancy. This is important for us to know the management, as we would see the medical management further in the management part of ectopic pregnancy. So what you need to know is, in the majority of the cases, you do not have a definite sign of pregnancy. You would have it only in around 15 to 20% of the cases wherein you see a definite fetal pole or a yolk sac. Okay, so this would be the definitive sign of pregnancy. When you have this in the annexa, you know it is for sure an ectopic pregnancy with a pregnancy test positive. But if you have this in the annexa, it raises the suspicion of an ectopic pregnancy. But you cannot be say for sure that it is indeed an ectopic pregnancy. Sometimes you see a pseudo sac in the endometrial cavity. This is the endometrial cavity, and what you can see is, you can see a sac-like structure. That is just because of the fluid collection, again because of the hormonal effect on the endometrium. So this should not be mistaken for a gestational sac. Even if you do a laparoscopy to confirm whether there is ectopic pregnancy, it is possible that if the ectopic pregnancy is too small, in 3 to 4.5% of the cases, you may miss to find an ectopic pregnancy, even if there is an ectopic pregnancy. So the false negative laparoscopy is 3 to 4.5%. So what I'm trying to say here is that no matter how good your sonologist is and your ultrasound is, you cannot always diagnose ectopic pregnancy with 100% guarantee, because you see the definitive sign of pregnancy in only 15 to 20% of the cases. Is this clear till now? Because this is important for you to understand for the rest of the session. Is this clear, everyone? Hello? Okay, thank you. And what we need to understand here, another thing that we need to understand is that your TVS can usually diagnose a pregnancy. TVS can diagnose a pregnancy when the HCG level is more than 1,000. Some consider more than 1,500, depends on the sonologist, depends on the machine and all those factors. But usually TBS can diagnose a pregnancy when it is more than 1,000. But the problem here is if it is an ectopic pregnancy, it may not always grow like a normal pregnancy. So the HCG may be more than 1,000, but you may not be able to see a normal pregnancy like a gestational sac, a yolk sac, a fetal pole, because it doesn't really grow normally because it is in the tube. So even if the beta HCG is higher, you may not be able to see an ectopic pregnancy for sure, the definitive signs of pregnancy in the ectopic pregnancy rather. Okay, so that's something that we need to remember. Now, this is an EMQ as far as the diagnosis is concerned. So a gestational sac should be differentiated from a pseudo sac. As I told you, a pseudo sac is nothing but fluid collection within the uterine cavity. A gestational sac is a fluid, basically a cystic structure which is eccentrically placed. Again, I'll show you the uterus. Okay, there is the endometrium here in the uterus. What happens in the gestational sac is it is eccentrically placed, while a pseudo sac is something that is distending the endometrial cavity. That is how you differentiate the two. A gestational sac has a decidual reaction with two concentric rings because it's the embryo that is getting implanted. It is the pregnancy that is getting implanted, trophoblast. So it is basically has two concentric rings, and there is increased vascularity around it because there is implantation. There is increased vascularity on Doppler, and it may contain a yolk sac, and that is of course the definitive sign, a yolk sac or a fetal pole. So this is something that you must remember in case there is a situation given and it is said that there is a central fluid filled space within the cavity with a query that it is a gestational sac. Remember, it could be a pseudo gestational sac. It may not always be a gestational sac. Now, so this is just a picture of an ectopic pregnancy, how an ectopic pregnancy would appear. As you can see, this is the uterus, this is the ectopic pregnancy here, this is the round ligament there. Okay, so that is how you would usually see an ectopic pregnancy on laparoscopy. Okay, now as far as the cervical ectopic and cesarean scar pregnancy diagnosis is concerned, it is not so important, but sometimes you may get it as an EMQ. So what you must remember is that in an cervical ectopic is basically where you have the uterus. Sorry, you have the uterus, you have the cervix. So cervical ectopic is where it is implanted here within the cervix. Okay, and what you can see here is nothing. Maybe you can see some fluid filled space here in the endometrium. You see the internal os above the ectopic pregnancy implanted area, and you see the cervical rim around the pregnancy. Another important thing that you would notice is that there is absence of sliding sign. Now, what does that mean? So if there was a pregnancy which was implanted on top in the uterus, and now it is in the process of miscarriage. What can happen? The pregnancy from the uterus on top can come and it just remain here in the cervix. What will happen is this thing will appear like a cervical pregnancy. It is not actually a cervical pregnancy. It is a pregnancy in the process of abortion. So now what happens is when you try to do TBS and you try to push onto the cervix with your transvaginal probe, what will happen is this particular pregnancy, which is not really implanted on the cervix, as you push the cervix upwards, this pregnancy would be pushed downwards because it is not really implanted there. What is happening is it is just lying there, it is trying to come out, and as you push the cervix up, it is trying to come out of the cervix. So that is sliding sign. So what happens here? an actual ectopic pregnancy, a cervical ectopic pregnancy, since it is implanted here, as you push the cervix up, the pregnancy is also going to be pushed up along with the cervix. So that is your absence of sliding sign. So that is something that you must know while diagnosing a cervical ectopic. So what are the signs of cervical ectopic? You have the empty uterus. Can you see that? Empty uterus is mentioned here. Empty uterus, a barrel-shaped cervix which has the pregnancy. The gestational sac present below the level of the internal cervical os as we had drawn. And there is absence of sliding sign and blood flow is present around the gestational sac. Okay, because it is implanted there. So this is how you identify an ectopic pregnancy which is in the cervix. All right. So if there are any questions any of you is having, you can. I will pause after every chunk of information that I give. So you can ask me questions. So I will ask you. Okay. So I would give everybody a chance to ask questions. So after this cervical ectopic pregnancy, let's see what happens in a cesarean scar pregnancy. There are ultrasound criteria for cesarean scar pregnancy as well, just like a cervical ectopic pregnancy. And cesarean scar pregnancy happens in 1 in 2000 pregnancies. Again, let me draw a sagittal plane. So this is the uterus, this is the scar, this is the cervix, this is the bladder here, and here is a rectum. Okay, so I have drawn the sagittal plane. Okay, you can see the bladder in front, the uterus, and there is the rectum behind. You don't see anything here in a cervical ectopic pregnancy. In a cesarean scar ectopic pregnancy, you see something here, or maybe a gestational sac, or just an inhomogeneous implanted structure there. The myometrium here may be thin. There is hardly any myometrium here because it is implanting there. So there is a thin myometrium. And there is evidence of prominent trophoblastic or placental circulation on Doppler. So whenever there is implantation in that area, you have prominent vascularity, obviously. And this endocervical is empty. So this is empty, and there is something here. There is a very thin myometrium there. So this would be your cesarean scar pregnancy. Again, a EMQ. Interstitial pregnancy. The incidence is 1 to 6.3% of ectopic pregnancy. And again, what you see is interstitial means there is a tube. Okay. There is the uterus. The myometrium or the endometrial cavity of the uterus is something like this. This part is the interstitium. So the part which traverses of the tube which traverses through the myometrium and reaches the endometrial cavity is the interstitium. So sometimes you get it here, that the pregnancy is here. So what happens here? Obviously, this part becomes thin. The myometrium, that part becomes thin. There is nothing here, empty uterine cavity. The products of conception or gestational sac are located laterally in the interstitial part of the tube and surrounded by less than 5 millimeter myometrium. So that is what I was mentioning. This is thin. There is a presence of interstitial line sign, that is thin echogenic line extending from the central part of the uterine cavity to the periphery of the gestational sac. So here you have the endometrium which is prominent because of the hormonal changes. And what happens is here this continues with the ectopic pregnancy, which also appears bright. So this is the interstitial line sign. So this brightness of the endometrium or the decidua continues onto the sac, onto the pregnancy. So this is a interstitial pregnancy, which can be mistaken for a pregnancy that is implanted on at the in the angular region, an angular pregnancy in near the cornu. Okay, so sometimes if the ultrasound is not sufficient, then you can use a 3D ultrasound or MRI whenever possible. So this is about interstitial pregnancy. Again, an EMQ. Cornual pregnancy, now it is not the same as the cornu of the uterus. It is basically pregnancy in a horn. If you have bicornuate uterus, for example, and say you have one side which is patent going into the cervix and the vagina, the other side is not patent. This part is not patent. So what happens? The cervix, the pregnancy grows here, and this is rudimentary horn. That means it is not going to grow further. It behaves like a tube, a little bigger tube. So what happens here is again you can have catastrophic bleeding here. And there is no, it is not opening into the uterine cavity, it is not opening into the cervix. It is just attached here as a rudimentary structure. Okay, so this is a cornual pregnancy. Again, not very common, 1 in 76,000. Abdominal pregnancy is also, again, you know that there is absence of intrauterine gestational sac, absence of both an evident dilated tube and a complex end nexus. Nothing in the end nexus, nothing in the uterine cavity. A gestational cavity surrounded by loops of bowel because it is in the abdomen, and it is separated from the bowel by the peritoneum, so it is in the general abdominal cavity, and a wide mobility similar to the fluctuation of the sac, particularly evident with pressure of the transvaginal probe towards the posterior cul-de-sac. So when you push on the pouch of Douglas, that is, which is posterior, the contents of the abdomen may move a bit. So, and if it is closer to the pouch, that the abdominal pregnancy will also start moving. Okay, so annexa is free, uterus is not involved. You see it surrounded by bowel loops. Okay, and there may be a fluctuation of the sac, particularly if it is closer to the cul-de-sac. And definite diagnosis, MRI, of course, because sometimes even a tubal abortion may look like it is an ectopic pregnancy. Tubal abortion is something where the tube extrudes the pregnancy into the pelvic cavity. Okay, so that sometimes appears like your abdominal pregnancy. So an MRI also may help in the diagnosis. As far as the ovarian ectopic pregnancy is concerned, again, here there is an empty uterus with a wide echogenic ring with an internal anechoic area on the ovary. Okay, so there is nothing in the uterus, but there is something in the ovary. And you may see a separate corpus luteum. Okay, so remember when there is ovulation on the ovary, you have the corpus luteum in the pregnancy, which persists for some time till the placenta takes over for pregnancy function. So that corpus luteum sometimes looks like an ovarian ectopic. But here in ovarian ectopic, you see something there in the ovary. You also see the corpus luteum, and it is not possible to separate the ovary from the cystic structure. So again, there is negative sliding sign. Normally what happens if there is an ovary and there is a tube and the tube has ectopic pregnancy, you can actually push the tube away from the ovary. But here, the if the ovary has the ectopic pregnancy, as you push the tube, as you push the ovary away with your transvaginal probe, the pregnancy will also move. So that is again, there is no sliding of the pregnancy. So that is negative sliding sign. And of course, you see a color Doppler, and sometimes you may be able to see a fetus there. So color Doppler will show vascularity there. All right. So this is less commonly asked, but can be asked. And yes, so can be asked as an EMQ. So is this clear so far? Any questions, anyone?
How to differentiate corpus luteum for the suspected ovarian pregnancy?
Well, it is, see, basically, you see two things there. That's a very good question, because sometimes what can happen is you can see a corpus luteum and even the pregnancy may look like corpus luteum, because both the things are cystic, isn't it? But if your beta HCG is high and you see two things here and nothing in the uterus, then you suspect. Again, this is suspicion. You suspect an ovarian pregnancy.
Okay,
Okay,
ma'am.
nothing in the tube, then again you suspect an ovarian pregnancy. Because you will not have two corpus luteum, you will have one, and if there are two, yes, you can have in multiple pregnancy, but it is extremely unlikely that both the pregnancies of the multiple pregnancy are not seen and the beta HCG is high. Okay, so when you have a corpus luteum in addition to something cystic or some inhomogeneous structure, it is likely to be an ectopic pregnancy. Coming to beta HCG. So as far as the rising trend of beta HCG is concerned, what happens normally in a viable intrauterine pregnancy is there is a rise by 66%. Okay, 63 is what is said in the guideline, but this is 66, approximately 63 to 66%. This is mentioned in the RCOG learning. So over 2 days, so 48 hours, you have a 66% rise usually. This is usual. Anything rising less than that doesn't mean it's not a normal pregnancy. Anything that is rising in the normal range, that is 66% in 48 hours, doesn't exclude an ectopic pregnancy. This is something that everybody should remember. So just because there is rise in beta HCG, which conforms to a normal pregnancy rise, it does not exclude ectopic pregnancy. All right, with this in mind, let's move on to management. Okay, so now this is important. If there is, sorry, if there is a positive pregnancy test in a woman of reproductive age group, and you're now in this case you're suspecting, say, ectopic pregnancy, the first thing that you want to look at is whether she's stable. That's the first thing that you want to look at. Okay, if there is a patient who's come, say, with abdominal pain and a little bit of spotting, pregnancy test is positive, the first thing that should come to your mind is an ectopic pregnancy, because all the other differentials like threatened miscarriage, your spontaneous miscarriage, all of those things are not deadly as ectopic pregnancy, as catastrophic as ectopic pregnancy. So what you need to do first thing is establish whether she's hemodynamically stable and whether there are any signs and symptoms of intraperitoneal bleeding. So now, if there are signs and symptoms of intraperitoneal bleeding, you will do an urgent surgical management for her with fluid replacement and all that. Okay, so that is straightforward. There is no doubt here. Positive pregnancy test, she's unstable. It is likely to be an ectopic pregnancy which has ruptured, and you need to do an urgent surgical management. Okay, of course, if she's come unstable, the scan that you would do would be a fast scan. Okay, so that is a scan which is called fast scan because it is done on an emergency, and it is done to check for hemoperitoneum particular, and if you can see any evidence of an ectopic gestation, the gestational sac. Okay, so this is what you would do in a in an emergency like this. Now next, if she is hemodynamically stable and there are no concerns of any significant intraperitoneal bleeding, what would you do is you would assess her history. Okay, now you have time, right? So you would assess her history, see if there are risk factors for ectopic pregnancy, and you would do a TVS with or without serum beta HCG. Okay, so you would do all these things. You will have to establish whether a tubal ectopic pregnancy is diagnosed or suspected. Now we have seen in the second slide what is diagnosed for sure and what is suspected. In majority of the conditions, this is for those who have joined late, in majority of the conditions, that is 50 to 60% of the cases, you will just see an ectopic gestation as an inhomogeneous mass, something like this. This is all that you see in the tube. Okay, in majority of the cases, in 50 to 60, that is tubal ectopic pregnancy suspected. Diagnosed is where you can see a gestational sac, a yolk sac. This may be enough for you to diagnose because you are seeing a gestational sac with a yolk sac, which is a definitive sign, and or a fetus. If you see a fetus, definitely it's an ectopic pregnancy. There is no doubt. So based on TBS and based on beta HCG, you can say either that you have diagnosed or suspected ectopic pregnancy. Now, is there any significant pain, end axle mass of more than 35 millimeter, fetal heartbeat is there, beta HCG is more than 5,000? What would you do? Anybody? What would you do in such a case?
Surgical management.
Yes. So in this case, you would do a surgical management straight away because there is significant pain. It is bigger in size. The beta HCG is high and fetal heart beat is there. So you would do a surgical management. Now, there is no significant pain and nexal mass is less than 35 millimeter. There is no visible fetal heartbeat, no intrauterine pregnancy, and there is minimal free fluid. In this case, what will you do?
Can give methotrexate to these patients.
All right. You can give methotrexate.
Expectant
Okay.
management also can be done.
Okay. 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 So you can give methotrexate or you can give expectant management. Now, as far as the NICE guidelines is concerned, you need to know the HCG level. Okay. Or even the GTG for that matter. So if the HCG is less than 1000 or as per the GTG, it is less than 1500. So anything less than 1500 from exam point of view, you can consider expectant because what happens here is you are a little safe or a little assured that since the HCG is so less, it is less likely to rupture. So you wait. Okay. Now, the question arises if she has beta HCG. Yeah, this is okay. Wait. Okay, so beta HCG of less than 1500. Also, you can give the option of medical as well if she doesn't want an expectant. Question arises is what happens if the beta HCG is 1500 to 5000. Here, what are you going to do? Okay, so here you can consider as far as the latest NICE guidelines is concerned, the NICE 2023 guideline, it says that you can give an option of medical and surgical. What does it say? That you can give an option of medical and surgical. However, the green top guideline, that is 2016, that's the older guideline, mentions that you can consider medical. Okay. Now, there is another important aspect here which is often ignored and it is not taken into account when we study this particular topic, and that is important. What is said in the Green Top guideline as well as the NICE guideline, the same thing. For such beta HCG, 1500 to 5000 particularly, when there is option of medical, what does the guideline say? This is what the guidelines mentions. So here it is, this is from taken directly. It's a screenshot of the Green Top guideline. So I have not written this on my own. This is a screenshot of the Green Top guideline. So the NICE recommends that methotrexate should be the first line management for women who are able to return for follow-up and who have no significant pain, an unruptured ectopic pregnancy with a mass smaller than 35, beta HCG between 1500 to 5000, and no intrauterine gestation. Okay, but remember, this NICE is the old NICE, 2012. This RCOG guideline is 2016. The latest NICE guidelines, which is 2023, mentions that for all this, you can give an option of surgery or methotrexate. This is what is mentioned in the latest NICE guideline. Okay, is that clear? So far is clear, everybody? Hello? Hello. Yeah.
Yes, ma'am, it's
Now,
clear.
the catch here is, yes, the catch here is they may give you a situation where, say, beta HCG is 2000. Okay. And a TVS finding is showing an empty uterine cavity, nothing, say, endometrial thickness is, say, 10 millimeter and doesn't have any yolk sac or gestational sac. And they will give you an inhomogeneous mass in the adnexa, and there is an ovary and nothing in the other adnexa. What would you do if it is this case?
What is the size of that ectopic pregnancy?
It is around 2 centimeter.
Ma'am will look for the beta SAG and follow up with the beta SAG whether it is rising in 48 hours or it is decreasing in 48 hours. And after
Mhm.
seeing the rise or fall, we can decide upon the type of management we are going to provide to the patient.
All right. Anyone else has any other opinion?
If patient is hemodynamically stable, then we can go for medical management.
All right. Anything else?
If there is no free fluid in the pouch of Douglas and if it is not ruptured, any collection is not there, and the patient is stable, we can
Hmm.
follow up with the beta SCG after 48 hours and
Okay.
see whether, and we can follow up in that manner.
Yes,
And
that
if there
is
is no
correct.
fetal hole, there is no FHS, there is no fetal, and
Correct.
the sac size
Correct.
is less than 35 centimeters, we can go for
Yes.
methotrexate
Right.
or
Right.
expect and
Right.
manage it if the beta SG is falling after every 48 hours. We can go for medical.
Absolutely, absolutely right. Absolutely right. Now, yes, here, as somebody said, they would consider medical management. Okay. Now remember, medical management should never be given in the first sitting. Okay. This is the first time that you are seeing this patient. This is her beta HCG is 2000, and there is no definitive sign of pregnancy. It is just an inhomogeneous structure, which is 2 centimeter, I said. There is no yolk sac, there is no gestational sac, there is no fetal pole. So this is tubal ectopic pregnancy suspected. This is not confirmed. This is suspected. Okay. So when there is a tubal ectopic pregnancy suspected, what the guidelines mentions and is often ignored is this. I'll read it out to you. However, before administering methotrexate, it is essential that the diagnosis of ectopic pregnancy is correct, as the majority of ectopic pregnancies are visualized as inhomogeneous masses. It is prudent to repeat the serum beta HCG in such cases in 48 hours. In the event of the serum beta HCG dropping, expectant can be appropriate. Should the serum beta HCG be rising at a rate that may be consistent with a viable intrauterine pregnancy, a repeat scan to check the diagnosis should be done before administering methotrexate. There are many well-documented cases of women with intrauterine pregnancies treated for suspected ectopic pregnancy with methotrexate. So methotrexate should therefore never be given at the first visit unless the diagnosis of ectopic pregnancy is absolutely clear and a viable intrauterine pregnancy has been excluded. So is that clear? So the first step that we do when you have such a situation, when you have beta HCG and you have TVS, of course, when the beta HCG in the range is in the range where you can where in the is in the range where you can consider medical management. You first check if it is tubal ectopic pregnancy suspected versus diagnosed. Diagnosed is when there is a fetal pole in the adnexa or there is a yolk sac in the adnexa. Then you know it is ectopic pregnancy. Then you don't wait. Then you give methotrexate provided there is no intrauterine gestational sac. Okay, so both the things should be fulfilled, that there is a diagnosed ectopic pregnancy in the adnexa, and there is no, it should not be heterotopic pregnancy, because then you cannot give methotrexate. It cannot be a viable intrauterine and an ectopic pregnancy. A rare situation, definitely, but you should be very sure before giving methotrexate. Okay, that you're dealing with a diagnosed ectopic pregnancy. Okay, if it is suspected, even if the beta HCG is in the range of 1500 to 5000, you will repeat after 48 hours. That's the first step, because of this particular uh, description here in the guideline, that you cannot say for sure if it is just an inhomogeneous mass in the adnexa, that is indeed an ectopic pregnancy. Okay, is that very clear, everyone?
Yes,
All
ma'am.
right.
Even if it is not in homogeneous mass, then also we'll have to do serum beta HCG in 48 hours to rule out the viable pregnancy.
What is it? If it is not an inhomogeneous
Like
mass, what is it?
heterotopic pregnancy. So, ma'am, even if it is like we can see yolk sac or fetal
No,
pole
no,
in.
no. That is exactly what I mentioned, no? If it is diagnosed ectopic pregnancy, heterotopic pregnancy will not be diagnosed based on 48 hours beta HCG, my dear. When you're saying diagnosed, it means there is hardly anything in the uterus. Okay, say ET is a little bit thickened, maybe 10 millimeter, and there is an ectopic pregnancy here, which has a fetal pole. This is a diagnosed
Ma'am, if
ectopic
it is
pregnancy.
intrauterine, I mean in heterotopic pregnancy, if it is intrauterine, then in that case, beta HCG will be more than 5,000 in all the cases.
Not necessary, based on how well your pregnancy has developed. But the problem is, in a heterotopic pregnancy, it happens usually because of ART usually, and you are putting both the pregnancies at the same time, isn't it? So this pregnancy and this pregnancy should be of the same size ideally. So you will not have a situation where this is ET is say 10 millimeter. Okay, and this is a grown pregnancy which is having a fetal pole and a yolk sac, and then you're thinking, oh, this also may further grow into a viable pregnancy and it may be heterotopic. This is not going to happen,
Okay.
because heterotopic pregnancy usually occurs at when you're putting two embryos at the same time. It is very rare in spontaneous conception. Even if it is spontaneous conception, then it may happen in the same during the same act of intercourse,
Okay.
right? So you will, and even in if there is this case, how will your 48-hour beta HCG tell you anything about this, about the heterotopic pregnancy? It will not tell you. Okay, because then in that case you are relying on HCG which is released by your ectopic pregnancy and HCG which is released by your intrauterine pregnancy. So your 48 hours beta HCG will not be reliable for a heterotopic pregnancy. So when you have a diagnosed ectopic, that is, you have a definite sign of pregnancy here and no sign of pregnancy here, that is a diagnosed ectopic. And in that case, you have your beta HCG 1500 to 5000. You can consider, sorry, this is not coming. You can consider methotrexate. Okay. Now, as we know that NICE guidelines mentions that it has to be an option of methotrexate versus surgery. You can go back to your NICE guidelines and check that. It is no longer mentioned in the NICE guidelines that 1500 and 5000 is only methotrexate. It is mentioned that for women with 1500 to 5000, give an option of surgery versus methotrexate. But in the exam, what will happen is usually you will get such a scenario wherein it is given that beta HCG is say 2000 and she's come with an inhomogeneous mass. And now what are you going to do? So answer should be repeat beta HCG in 48 hours. If they tell you that, okay, it was 3000 and now the beta HCG has become 4000, So from 3000, it has risen to 4000. So it is definitely not risen more than 50%. Okay, it is risen, but it has risen slightly. So after that means it is not likely to be a viable pregnancy. Then you repeat an ultrasound, and if it is still showing that inhomogeneous mass, then you can give methotrexate. Okay, so if that is not mentioned, it is the first value of beta HCG, then you will choose the answer repeat after 48 hours if it is not a definitive diagnosed pregnancy. Is that clear? Anybody has any questions? This is very important. Okay, so again, to reiterate that if the diagnosis of ectopic pregnancy is not confirmed, that there is no yolk sac, no fetal pole, there is just an inhomogeneous sac, less than 35 millimeter, and viable intrauterine pregnancy has been excluded, methotrexate must not be given at the first visit. So if the ectopic is not confirmed and intrauterine is not excluded, and is excluded, then then methotrexate should not be given at the first visit. Okay, is that clear, everyone? Can I get some response, please?
Yes, ma'am.
All right.
Clear.
Now, okay. So for women with a tubal ectopic pregnancy being managed expectantly, repeat HCG levels on days 2, 4, and 7 after the original test. And if the HCG levels drop by 15% or more from the previous value on days 2, 4, and 7, then repeat weekly until the negative test. Negative is considered less than 20 international unit per liter. Okay, so until a negative test is obtained, if for an expectant, so it is say less than 1500 or 1000, say it is say around 900 beta HCG. Okay, and you are seeing some inhomogeneous structure in the NXA, or you are not really seeing any definite pregnancy. It's a pregnancy, say, of unknown location. And you repeat after 48 hours is day 2. You repeat on day 4. And you repeat on day 7. Okay, there has to be a consistent 15% drop. Okay, 15% and 15%. All right, if that drop is occurring, then you do weekly beta HCG till it is negative. And if the drop does not happen at that rate, if the HCG levels do not fall by 15%, or they stay the same, or rise from the previous value, review the clinical situation of the patient and seek senior advice to help decide further management. Okay, it is also possible that since it is 900, you have decided to wait. On day 2, you have done a beta HCG and that has become, say, 2000. What will you do next? Say there was some irregular structure in the adnexa, a very small 1 centimeter irregular structure in the adnexa, nothing definite, nothing in the uterus, nothing in the ovary. So if it was 900 and now it has become 2000, what will you do? Anyone?
We'll follow up on the fourth day again to see whether it is rising or not.
Mm-hmm.
We'll repeat the beta HCG after 48 hours and we can see whether it is rising or not.
So you
Whether
are going to repeat beta HCG after 48 hours of 2000?
It can be intrauterine pregnancy, so
Yes, but listen here, you have to also note that it has risen at a level which is almost consistent with an intrauterine pregnancy, right?
yes.
It has more than doubled. So what will you do to check? Next step.
TBS.
Exactly, you'll do a TVS
Okay.
because TVS may not have diagnosed the ectopic pregnancy or the intrauterine pregnancy at 900 because the beta HCG was less. And now it has become 2000, and it is possible your TVS will diagnose the pregnancy now because it has risen very well, And it is possible that now with the TVS, you will be able to see the pregnancy. Okay, so that should be uh, your thought process. So you need to understand whether there is, in the first place, whether this is what kind of pregnancy, whether it is pregnancy, ectopic pregnancy suspected, ectopic pregnancy diagnosed, or pregnancy of unknown location. What does that mean? Pregnancy of unknown location is when there is nothing seen on ultrasound. Ectopic pregnancy suspected is when there is inhomogeneous mass seen on ultrasound in the end nexa. And ectopic pregnancy diagnosed is when there is a definitive yolk sac and a or a fetal pole in the head nexa. That would be diagnosed. So for the first two, that is ectopic pregnancy suspected and ectopic pregnancy of or unknown location, pregnancy of unknown location. If the first beta HCG was low and now suddenly it has risen, you always repeat TVS. Okay. If the first beta HCG is low, you have done expectant and now it has dropped more than 15%. You don't have to repeat TVS because it has dropped. It is likely to be a failing pregnancy no matter where it is. Why do you care if it is a failing pregnancy, right? Why would you want to do a TVS and check where it is? It is anyway a failing pregnancy, right? So if it is falling more than 15% on day 2, you do on day 4. Okay, so that is how you should be proceeding with diagnosis of your ectopic pregnancy. All right, is that clear? Okay, so coming to follow up for medical management. Now, if for women with ectopic pregnancy who have had methotrexate, take 2 serum beta HCG measurements. In the now methotrexate is given, that means you know for sure it is ectopic pregnancy. Otherwise, you wouldn't have given methotrexate. We have established that. Okay, so you have given methotrexate, that means it is for sure an ectopic pregnancy. So now you're going to take 2 values on day 4 and day 7 after treatment of methotrexate and 1 beta HCG per week till negative. Okay, so you are doing today and you're giving methotrexate today, say. After the previous, say, beta HCG was, say, 3000. Okay, and you're giving methotrexate today. So today would be day 0. Day 4 you do beta HCG and day 7 you do beta HCG. Now, when will you say your treatment is adequate? When the beta HCG drop between day 4 and day 7 is more than 15%. Okay. If it is more than 15% between day 4 and day 7, then you can relax and say that, okay, this is fine, and follow up with weekly beta HCG till it is negative. Okay. So if this drop is more than 15%, you will do weekly beta HCG till it is negative. Now, the question is, what happens if the drop is not more than 15%? If the drop is not more than 15%, then you repeat your TVS to see what is happening to the pregnancy, or if there is any free fluid, or if that pregnancy has grown, or if there is an ectopic fetal cardiac activity and there is hemoperitoneum, then you do a TVS. Okay, so if the drop doesn't occur optimally, you do a TVS. If the drop occurs optimally more than 15%, then you follow up the patient weekly. Okay, now for example, if you have done your beta HCG is 3000 on day 0, you have given her methotrexate. On day 4, the beta HCG is now, say, 3500. What will you do next?
TVS we can do.
Mhm. Anyone else? Yeah. Anybody else has any other answer? Okay. Now, Be careful here. When you give methotrexate, what you're doing is you're destroying the pregnancy. You're destroying the pregnancy. What happens as a result of destruction of pregnancy tissue? Your HCG is released in the system. Your HCG actually rises. Okay, because trophoblastic tissue is getting destroyed. So your day 4, which has risen slightly, should not be considered. You have to repeat day 7 beta HCG. Okay, that is why if the beta HCG level decrease by more than 15% between day 4 and day 7, okay, then you measure weekly beta HCG. They have not said between day 0 and day 4. They have said that you repeat on day 4 and day 7. And if there is a drop or by more than 15% from day 4 to day 7, then you do weekly. So it is possible that when you have your 3500 beta HCG on day 4, on day 7 when you do, it will come back to or it will fall. Say it will become 2000. Okay, is that clear?
Yes, ma'am.
Yeah. Often you notice if you have been practicing clinicians, if you give methotrexate, it rises on day 4. If particularly if it is not very low beta HCG. Okay, it will rise on day 4, and from between day 4 to day 7 is the drop that you check. While in the expectant management, when we saw earlier, it was since you're not giving any beta methotrexate to destroy the pregnancy tissue, so you expect the fall to be consistent. So you are checking fall on day 2, day 4, and day 7 in a consistent way. From day 0 to day 2, it has to fall more than 15%. Day 2 to day 4, it has to fall more than 15%. Day 4 to day 7, it has to fall more than 15% for expectant, not for medical. Medical, day 0, methotrexate, day 4 may actually rise, and what you have to look at is the fall between day 4 and day 7. And now here, if it rises, then your TBS. And rule out hemoperitoneum, rule out an increasing size of the ectopic pregnancy or a cardiac activity. If that is the case, surgery. Okay, this is how you need to do your EMQs and your SPS. All right, so then 85% would be the success rate of medical management. Second dose may be required in 15% of the cases. Surgery is required in 7% of the cases, is what we discussed. So when there is no adequate drop, you do a scan and then you see hemoperitoneum. That's the 7% requiring surgery. Side effects. The most common adverse effects are excessive flatulence and bloating due to intestinal gas formation, a transient mild elevation in liver enzymes, and stomatitis. These are the common side effects. Other side effects which can be severe would be marrow suppression, pulmonary fibrosis, non-specific pneumonitis, liver cirrhosis, renal failure, and gastric ulceration. So these are the severe side effects. And you have the common milder side effects. All right. Contraindications to methotrexate. Also check your question if there is any contraindication given there to methotrexate. Okay, check if there is hemodynamically instability, presence of any intrauterine pregnancy, you should not give. So heterotopic pregnancy, you should not give methotrexate. Okay, if she's breastfeeding, you should not give methotrexate. If she's unable to comply with follow-up, don't give. If it is, look out for these cues in the question. Let me tell you that the patient is not going to follow up, okay, or patient is traveling or whatever that is. So if she is not able to follow up, you don't give methotrexate. If she's sensitive to methotrexate, she's allergic to methotrexate, do not give methotrexate. If she has having chronic liver disease, do not give methotrexate. Okay, pre-existing blood dyscrasias, active pulmonary disease, immunodeficiency, peptic ulcer disease. Okay, so the first thing that you need to assess when you're giving methotrexate is first assess whether the beta HCG is in the range 1500 to 5000 and all other criteria are met. Hemodynamically stable, she is less than the sac is less than 35 millimeter, on all those criteria are met. Okay, Next thing is you check whether it is a diagnosed ectopic pregnancy or suspected ectopic pregnancy. If it is suspected, repeat after 48 hours. If it is diagnosed, check if there is any heterotopic pregnancy. That means there is something sitting in the uterus which is also looks like a pregnancy. If it is not, you can give methotrexate provided all of these criteria are met. She is willing to follow up. She has none of the medical conditions, no medical conditions which would make her, unfit for medical management. And yeah, so these are the criteria that should be met. So she's willing for follow-up, she's not breastfeeding, and no medical conditions that would make it unsafe for medical management. So this is the flow, okay, that you need to follow. Okay, so first thing is diagnosed or suspected ectopic pregnancy. Okay, suspected, repeat in 48 hours. Diagnosed, then rule out intrauterine pregnancy along with an ectopic pregnancy. And if there is no intrauterine pregnancy, give methotrexate. So this is how you would follow. Okay. Surgery, the route that is used for surgery is laparoscopy, which is commonly, even in hemodynamically unstable, nowadays, laparoscopy surgery is being used commonly, although earlier it was said only laparotomy, but nowadays it is used because of the skill that is developed in laparoscopic surgery. Nowadays, we are using even laparoscopy for unstable patients as well. Salpingectomy is to be offered to women undergoing surgery for an ectopic pregnancy unless they have other risk factors for infertility. So if there is a patient who has come to you, say primary gravid patient, or even otherwise if she's come to you with a multi patient who has no other risk factors for having an ectopic pregnancy, that means she has never had extensive surgeries in the pelvis, or she's never had endometriosis, she's never had PID. Okay, all these conditions that can increase the risk of your ectopic pregnancy, she's not had. Okay,
And
and
I
now
have
she
one
has
question.
a
Sorry
hello,
to.
yeah,
Yes, ma'am.
yeah, tell me, tell
Actually,
me.
ma'am, I've also done many laparoscopies in unstable patient of ruptured ectopic. But ma'am, if it
Yeah.
comes in question, so what are we
Hmm.
supposed to? We are supposed to choose only laparotomy, no? If the patient is unstable, it hasn't changed in the guidelines, no?
Um, no, it has not changed in the guideline. It is not definitely given that it is laparotomy.
So,
Okay,
ma'am, will
so
choose laparotomy
you
in
may not get a question where they would say that there is laparoscopy and there is laparotomy. You may get a question where the option is surgical, medical, and such things. Okay, so because none of the places they would say code definitely for laparotomy. None of the places. Okay, they would just say that in the guideline also they would say that laparoscopy is now increasingly being done for a patient who's unstable. Okay.
so in case
Um,
we have to choose, we'll choose laparoscopy.
I don't think you will get a question like that wherein there has to be, see, there has to be a clinical scenario, right? There is a patient who is hemodynamically unstable. Okay. And it is mentioned to you that this is an ectopic pregnancy. What would you do as the next line of management? You will choose surgery. They will usually give you a surgery as the option. Okay, usually they will not give you an option where you can have both the answers as right. Okay, it is nowhere given that it has to be laparotomy for a patient who's unstable. It is not clearly mentioned, although earlier, yes, it was mentioned that you wouldn't consider a laparotomy for a patient a laparoscopy for a patient who's unstable. Yes, that was there. But now, if you see the recent guidelines, if you see the recent material, and even the RCOG e-learning, if you see there as well, they say that you can consider laparoscopy. So it is what the questions that you typically would expect in the exam is just to choose the surgery. I mean, a surgical management. Okay. In the surgeries, they may not give you options as laparotomy and laparoscopy. All right.
Okay.
Okay. So that is what it is. So as far as this is concerned, as far as the option, what to do, that is the important. This is what they ask you typically. When do you do a salpingectomy and when do you do a salpingotomy? Okay, so you will remove the tube entirely when you know that she doesn't have any risk factors for your ectopic pregnancy. So there is the tube, the uterus, okay, and there is an ectopic pregnancy here. The other tube is absolutely normal. You will choose to knock this off because if you just cut this part or or just make an incision here and take this tube out, the pregnancy out, and then suture it back, there is a possibility that the ectopic pregnancy may occur again over here. So rather, you take away the damaged tube entirely and give her one healthy tube rather than keeping one damaged tube and one healthy tube. Okay, because when you have a damaged tube, you can have an ectopic pregnancy here again. However, if this is damaged, okay, if this tube is say having, there is endometriotic deposits, there is evidence of say the tube is looking unhealthy in the sense the femria are stuck to each other. Okay, for example, then
Hydrocele.
you will do salpingotomy. You will not do a removal of the tube because then you have to give her whatever chance possible because the other tube is unhealthy. But if the other tube is healthy, you give her the best chance. That is how it is. So you remove the tube that is damaged already now with the ectopic pregnancy. Okay. So salpingectomy would be chosen. Salpingectomy may be chosen if the other tube is healthy and no risk factors for infertility. Salpingotomy would be chosen if there are risk factors for infertility, other tube is unhealthy. Clear?
And if the other tube has hydrocephalus and one tube has
Hmm.
ectopic, then both tubes must be removed, right?
But that is again, if the other tube has hydrosalpinx, yes, both tube must be removed. But you have to first, I mean, such a situation, you have to first counsel the patient about the risk of IVF and all those problems would be there. Provided you have taken a consent previously, yes, you can remove. But for this, you have to proceed with the fact that I would do a hydrosalpinx removal. Okay. You're saying there is hydrosalpinx even in the tube which is having the ectopic pregnancy. Both the tubes having
No,
hydrosalpinx.
no, the uh, tube which does not have pregnancy, but it has hydrocephalus. So if we haven't taken consent, then we cannot touch the tube, no?
Yeah,
The
exactly.
two
So you will
nipple tube.
not. But you will touch the tube only if you have taken consent. One thing. And in that case, what will you do in the indexed pregnancy in the other tube?
We will just leave it, no? If consent is not there.
No, no, no. If there is say right tube, this is what you're saying. As far as I've understood, you're saying there is a hydrosalpinx in one tube and there is an ectopic pregnancy. Okay.
Yes.
Say you have diagnosed hydrosalpinx antenatal before surgery. You have taken consent for removal of the this tube. What will you do to this tube?
Then we'll remove if consent is there.
Yeah, that is fine. What will you do to the other tube which has the ectopic pregnancy?
Selfingotomy.
Yeah, it's the same thing. So when there is a salpingotomy, I mean when your other tube is unhealthy, it comes back to the same situation that we discussed. You will do a salpingotomy. Whether you will do the procedure here or not is a totally different situation. Suppose there is endometriotic chocolate cyst here. What will you do? Will you remove it? Will you remove a chocolate cyst if you're doing a ectopic pregnancy surgery?
Depends, like
If the
your
patient has given
yeah.
consent, then only we can touch the other tube.
Exactly. Yes,
Without
yes. So
consent, we can't.
exactly, if you have worked up the patient for that and you have taken consent, then yes. If you have not taken consent, you will not touch it. Okay? So that is how it is. Okay, so this is a completely different scenario that you're discussing. This is if that particular patient is evaluated and you have taken consent, you have done the workup for the patient, and then you proceed. that's a different situation. But on table, if you find something is happening and something is pathological, you have to decide whether you have to do salpingotomy or salpingectomy. In that case, you will do a salpingotomy in this case. All right. So that is how it is. Okay. Right. So, yeah. So one study found, this is given in the strategy, that subsequent intrauterine pregnancy rates of 75% with salpingotomy and 40% with salpingectomy in such women. Which women? Women that have infertility factors. Okay. So if you remove the tube, which has the ectopic pregnancy, the chance that she would have a healthy intrauterine pregnancy later is less when you do a salpingectomy. While if you do a salpingotomy, the chance is much more. So that is what it is, the rationale to consider a salpingotomy instead of salpingectomy in such women with infertility. Okay. Yeah. So what other thing that you need to take care of after a salpingotomy is that you need to take a serum beta HCG at 7 days after the surgery and then every week until there is negative test. Okay. So you need to basically, when you have done a salpingotomy, it may be possible that you have left a few trophoblastic tissue in the tube. Okay. So those may produce beta HCG and may then persist, may result in hemorrhage, etc., etc. Or it may result in something like a molar gestation, okay, GTN. Okay. So that is why when you have done a salpingotomy and removed only the unhealthy pregnancy from there, you would need to monitor her beta HCG levels every week till it is negative, because persistent trophoblast rates after salpingotomy is 3.9 to 11%, so not very low. That is why you need to monitor beta HCG levels after salpingotomy. What about salpingectomy? Because you have removed the entire tube, are you going to just leave them alone? You need to offer them a urine pregnancy test, okay, after 3 weeks. Sorry, after 3 weeks. Okay, is that clear? You will need to follow a urine pregnancy test for them after 3 weeks. Okay, so it is not beta HCG, remember. It is just a simple, because you have removed the entire tube, you are not worried actually, but you want to be very sure that the pregnancy is out and you've not done something, where you've not operated on the wrong tube, or there was another pregnancy growing there. So you don't want such a situation to occur. Okay, so in that case, you need to just do a pregnancy test, and if it is negative, uh, you can just be rest assured that there is nothing wrong with the patient. Okay. We'll move on to miscarriage. Everybody is ready. Any questions on ectopic pregnancy? Miscarriage also is short. Is short rather than ectopic pregnancy was long. Any questions? Okay, so what we need to remember there in ectopic pregnancy is do not give methotrexate at the first sitting if your ectopic is not established. Okay, if it is suspected and if it is pregnancy of unknown location, always repeat after 48 hours. So that's something that has to be very clear. That's a concept that has to be very clear. Okay, coming to your miscarriage. Here also there are a few concepts that we confuse, and let's look at those. So if there is miscarriage and say there is bleeding or spotting in early pregnancy, you will do a TVS. Okay. Once you do a TVS, now we are not looking at ectopic pregnancy. Yes, there is bleeding or spotting in early pregnancy. That it can be an ectopic pregnancy, but just look at the possibility of this being a miscarriage. Okay. And you have done a TVS that shows a fetal pole. Now, intrauterine, okay, we are not looking at ectopic pregnancy. Intrauterine fetal pole is present. Then what do? You check for heartbeat. Fetal pole is present, heartbeat is present. What does it mean? What is the diagnosis now?
The fetus is growing.
Yeah, so what is the diagnosis of this condition?
It can be a threatened miscarriage.
Yes. So the diagnosis is threatened miscarriage.
Yeah,
Okay. There is a good baby, but you have come with spotting,
yeah.
bleeding. Okay. So that's a threatened miscarriage. Okay. Then, if there is previous history, so when there is a diagnosis of threatened miscarriage, you have to check whether there is previous history of miscarriage. Why? If there is previous history of miscarriage, if there is no previous history of miscarriage, let's see first, you can just reassure. Don't do anything. Just wait. Okay, she's come to you for the first time. She has no previous miscarriage and she's in early pregnancy. She's spotting, but you have done an ultrasound and you've seen that the baby's heart is normal. You don't have to do anything further. Okay. However, if she has a previous miscarriage, what would you do for her? Anybody?
You can give her micronized progesterone or the first month such type of drug can be prescribed to her to prevent that threatened miscarriage. To proceed
No,
to
yes, that's right. But since we are following guidelines, we have to just go by guidelines. So it is only micronized vaginal progesterone that you would give 400 microgram BD till 16 weeks.
16 weeks.
So this is the indication for micronized progesterone. Okay. So this is one thing. The second situation could be where you have no heartbeat. What are you going to do? Fetal pole is there. There is no heartbeat. What are you going to do?
We will repeat the beta SCG, or we can go for TVS after 7 days
Why beta HCG?
to see whether it is an inevitable abortion or whether it is a missed abortion.
Only
Such type of
TBS is repeated, no, after
So
7 days.
how will a beta HCG help you in that case?
whether the
You're
fetus.
already seeing that it's a intrauterine pregnancy, no? So
Yeah,
how will a beta HCG help you?
madam. So we can find that whether it is going to become an inevitable pregnancy or a missed miscarriage. So we can follow
Yeah,
with
so
beta SCG and TVS.
no, what I'm asking you is why are you doing a beta HCG? How will that help you? What information would a beta HCG add to TVS? Because on TVS you're already seeing the baby, the pregnancy.
Yeah,
So now does the beta HCG help you at all?
no, not actually.
No, it doesn't help at all. Once you see the baby, you see the baby, you see the pregnancy. Now the beta HCG is not going to help you.
I
Okay,
think she wants to say that if it is a failing pregnancy, then it will decrease further. That's why
decrease.
she
Yeah.
said
Yes,
beta.
but I know what she's saying. But if, how is it adding to your situation? You're doing a TVS, isn't it? If it's a failing pregnancy, your TVS will tell you, isn't it?
Yes.
So how will your beta HCG help you?
No, it's not.
Here, you have already seen the fetal pole there. It is not a situation where you have not seen the fetal pole. Then it's a different situation. Then it becomes pregnancy of unknown location, unknown viability, all of those things. Here, you have seen fetal pole in the uterus. Okay, so when you have seen the fetal pole in the uterus, the only modality that is used for follow-up is a TVS. Yes, Dr. Rashmi,
Yes, ma'am.
you raised your hand. I thought you raised your hand. Okay, never mind. So, you have to do a CRL measurement, right? The CRL, when you have a fetal pole in the uterus, okay, you do the CRL, the crown rump length. Okay, so that is what you do when you have a baby in the uterus. Because you have to be very sure that it is indeed a failing pregnancy. How can you be sure now? If the CRL is less than 7 mm and heartbeat is not seen, it may mean that the pregnancy is too early for you to see a heartbeat. You can see the CRL, but that means you can see the baby, but maybe that you can't see the heartbeat because the resolution of your transvaginal scan is not that good. Okay. because it is too early a pregnancy. So how will you rule out? In 7 days, definitely this pregnancy, if it was viable, would grow.
Mm.
So that is why you repeat in 7 days. And that is why your beta HCG will not help you, because if this pregnancy is viable, it will anyway grow on TVS. So adding beta HCG to that doesn't help you. Okay. Now, if the CRL is equal to or more than 7, why we consider 7 as the cutoff? Just like how we have 1000 as the cutoff for beta HCG for you to see a pregnancy on TVS. Similarly, for CRL, it is 7 millimeter. Okay. For you to see heartbeat, it has to be 7 millimeter. Less than 7 millimeter, given that the resolution of the ultrasound is such that you may not be able to see heartbeat, less than 7 millimeter. Okay. More than 7 millimeter or equal to 7 millimeter, and there is no heartbeat, that means it is likely to be a miscarriage. But we do not diagnose miscarriage again in the first shot. That is another dictum. Do not diagnose miscarriage in the first shot. Okay, even if it is more than 7 millimeter and there is no heartbeat, you still give her a benefit of doubt. So what does the guideline say here? Anybody knows? Anyone?
Measure the crown rump length, ma'am.
We are measuring 7 millimeter is CRL here.
Yeah. Okay.
Okay, so here what do you do as per the guideline? Since you have done your CRL, that is your crown rump length, and it is more than 7 millimeter, you expect to see a heartbeat, but you can't see a heartbeat. You are suspecting miscarriage, but you want to give the patient the benefit of doubt. In that case, you repeat either after 7 days TVS or seek second opinion. One of the two. Here, for sure, you will repeat TVS after 7 days. Here, either repeat after 7 days, give her the benefit of doubt, or you can seek a second opinion. All right. So if it is in the exam, if you have a situation where the CRL is say 8 mm, okay, and there is no cardiac activity, what will you do? What will you do? You will either repeat TBS after 7 days, or at this point you take a second opinion. Okay. So one of now, if it is mentioned to you, she's CRL is 8 mm, cardiac activity is not there, and you have sought the opinion of another sonologist who has also checked the CRL and he finds it is 9 mm, cardiac activity is not there. What will you do now?
Give medicine.
Yeah, basically I'm asking you about diagnosis. So now you will diagnose as miscarriage. Okay, we are looking at diagnosis. We have not yet reached the medical management or the management. Okay, and not all miscarriages would be dealt with medically. Remember that. Okay, the first line, in fact, is expectant management. Okay, so what I'm trying to tell you here is if the CRL is more than equal to 7 millimeter, before you diagnose her as miscarriage, you have to either take second opinion or repeat after 7 days. If you have done one of those, that is, you've taken a second opinion and it is still showing the same, you can diagnose as miscarriage. Or you've not taken a second opinion, you've called her after 7 days, and after 7 days it is still showing the same. That's when you diagnose as miscarriage, not at the first go. Not here, not at the CRL less than 7, not at the CRL less than 7, or here. These two boxes, you will not diagnose at this stage that it is a miscarriage. You have to, in this case, you have to repeat in 7 days for sure. In this case, you have to either, in the second case, you have to either repeat or takes a second opinion. Is that clear, everyone? Is that clear? Any questions so far? Okay.
Madam, can I repeat what you have said so that I
Yeah,
can
sure.
understand? Madam,
Yeah,
if the CRL is less than 7 and there is no heartbeat, we are going to repeat the TVS in 7 days and see whether the
yeah,
heartbeat has come or not. If the heartbeat
yes,
is has come, then we can diagnose that it is a viable pregnancy and we can follow up in the next few weeks again.
correct,
And if the
correct.
strong lump is CRL is more than 7 and there is no heartbeat, we are going to repeat the TVS in 7 days or take a second opinion to find out what is whether the
Hmm.
pregnancy
Hmm.
viable.
Correct, correct. And you can diagnose it as a miscarriage only after the second step.
Okay.
After the second step. So here you can see the boxes. After the second step, that is, in the first case you have repeated after 7 days, or in the second case you have repeated after 7 days, or say, sought a second opinion. After that, you can diagnose as miscarriage, not at the first step. Even though the CRL is more than 7 and you're not getting heartbeat, you cannot diagnose in the first step because it can be an error. Okay, it can be an error of measurement of the CRL.
Okay.
Okay, so that is why. So you give the patient the benefit of doubt.
Okay.
Okay,
Okay. Thank you.
now, yeah. So now, if the fetal pole is say absent, okay, and now you have just the gestational sac. You don't have the baby there. You have a gestational sac. It looks exactly like a gestational sac. It is eccentrically placed. It has the double decidual sign. Okay, it does not look like a pseudo gestational sac. It is a gestational sac, intrauterine gestational sac. What will you do? And she's come with spotting. Okay, so you are suspicious whether it is a viable pregnancy, not viable pregnancy. So what will you do here? Measure the gestational sac, mean sac diameter, right? Right? So what is the cutoff of the mean sac diameter above which you should be able to see a CRL or a baby? Anybody?
25 millimeter.
Yeah. So above 25 millimeter, technically you should be able to see the fetus and all that. But if it is less than 25 millimeter, that means it is possible that it is too early for you to see the baby. In that case, what you do is you repeat TVS after 7, just like what we would do in the first case here. Okay, if it was CRL less than 7 millimeter. So what you would do here in the first case, the same thing you would do if the gestational sac is less than 25 millimeter. Okay, here if the fetal pole is not there, if the fetal pole is there, you measure the fetal pole, not the gestational sac. Here it is gestational sac, there is no fetal pole. That is when you do this exercise. Okay. Now, the second situation is just in the other second situation of CRL. GS is more than equal to 25. What will you do? What will you
Repeat
do?
scan.
Repeat the
Again,
TVS.
give her the benefit of doubt.
Yeah.
One of the two things. Repeat scan. See, this chart, if you remember, should be good enough. So, either you repeat scan or you seek a second opinion. Okay. But remember, below, say for example, you have seen a gestational sac of 14 millimeter today. Okay. After say 7 days, now you are seeing a gestational sac of 25 millimeter. What will you do? Okay, so today you have done a scan and your gestational sac is say 14. Okay, and after 7 days, you have done a scan and that is coming as 25. Now what you'll do?
We'll see if fetal pole is present or not. If
Oh,
it is
there's no
present,
fetal pole. There is
Then
no
we'll
fetal pole.
We'll seek a second opinion.
That was a good answer. You will, yes, you will seek a second opinion, definitely, and it will be the second this particular box, because now it has, what you have seen is it has grown, right? It has grown from 14 millimeters, has become 25 millimeter. That means there is still a chance, right?
Yeah.
So
Yeah.
it would be, although it has become, in a 1 week, there is no fetal pole that you have seen, but the gestational sac is grown. So you still give her a chance. You take a second opinion or you do a TBS. Okay? Because remember, the first thing that you should do, or always the thing that you should do before rushing into the diagnosis of miscarriage, is be very sure that she's indeed having miscarriage. Just like
Yeah.
how in the medical management of ectopic, you should be very sure that it is an ectopic. In diagnosis of miscarriage, because it's a bad news that you're giving the patient. Most of the patients will not
Ma'am,
like
we'll
the news of
do
miscarriage.
TBS after 7 days again.
Yeah, after 7 days of the next one, no, because it has grown. There is an interval change. If it
Mm.
has not, see, it was 14 millimeter today. By guidelines, you will do a TBS after 7 days, right?
Mm.
Yeah, by this particular thing, you will do a TBS here, right? Now, if from say a gestational sac of 25 millimeter or 14 millimeter, say it has just grown a little bit maybe, or not grown at all, or it has now become all shrunken, then you know it is miscarriage, right?
Mm.
But when there is something that is growing at an interval, and now it has reached 25 millimeter, and now you have to understand that 25 millimeter is actually the cutoff at which you should see the heartbeat. So at the earlier scan, when it was 14 millimeter, it is possible that you cannot see the heartbeat or cannot see the baby, fetus, the CRM, right? So 25, when the moment it reaches 25 millimeter, after 25 millimeter, after a week of 25 millimeter, you still don't see the fetal pole, then it is a miscarriage. So your cutoff has to be 25 millimeter. Okay. If it is anything less than 25 millimeter, say 14 millimeter, and now after a week, you have done a scan which is around this almost the same, say 16 millimeter, and there is still no CRL. Now what it becomes? What does it become?
That is diagnosed as miscarriage.
Correct. Now you can diagnose miscarriage, because it should, if it was a viable pregnancy, it should have definitely grown. Okay. When, why I said in this first case you will repeat after another 7 days is because at the end of the first 7 days, it has grown to a level where you should be able to see a CRL. And at that time, you may make an error and not see the CRL because of resolution, because of you couldn't see the CRL at that particular point, or whatever the factors may be. There you give the benefit of doubt, because that's when it has crossed 25 millimeter. But when it has hardly grown over a period of 7 days, it cannot be a viable pregnancy. A viable pregnancy grows rapidly, isn't it? So you cannot, basically, when it is, what is important for you to remember, or most of the questions would be, in this case, would be straightforward. And if it's CRL, you have to see, or gestational. First, you have to see whether there is gestational sac or CRL. Okay, if there is CRL and you see that the CRL is less than 7 millimeter, no heartbeat, then you know that it is possibly a miscarriage, but you have to confirm after 7 days. Okay, so if it is CRL is more than equal to 7, no heartbeat, very much likely it will be a miscarriage, but still give a benefit of doubt. And in that case, you either take a second opinion or you repeat the ultrasound after 7 days. Okay, is that clear, everyone?
Yes, ma'am. That's clear.
Yeah, yeah. So the first thing, so when you have a gestational sac only, you measure the gestation. That is what you need to understand. When you have a gestational sac only, because gestational sac appears before the fetal pole, right? So when you have the gestational sac only, you measure the gestational sac. When you have the gestational sac with the fetal pole, you measure the CRL. Okay, so that is how you have to check your questions. Now, if for miscarriage, for diagnosis of miscarriage, the other thing is if you have done a TAS, okay, if you've done a TAS, say patient is not allowing you to do a TVS, patient doesn't want a TVS, patient is not comfortable with TVS. And if you see the gestational sac, but you don't see the fetal pole, okay, on TAS, you will record the CRL or MSD depending on what you see. Okay, if you see the CRL, you record the CRL. If you see MSD, that is the gestational sac, and you don't see the fetal pole, you just record the gestational sac. Okay, and in this case, instead of repeating 7 days in TBS, here you would repeat in 14 days because TAS is less sensitive to diagnose a pregnancy in the uterus because it is in the pelvis as compared with TBS. So whenever you use a TAS and you cannot see things clearly, just say that you would repeat the scan after 14 days. All right? Is that clear? Okay.
Yes, ma'am, it's
Okay.
clear.
Now, pregnancy of unknown location, another important aspect, ectopic pregnancy beta HCG. So this is what was earlier we were discussing. It's the same thing. The value is rising more than 63%. Likely to be a good pregnancy, but you cannot exclude ectopic pregnancy because an ectopic pregnancy that is growing in the say in the ampullary region maybe of the tube would also initially grow like a normal pregnancy because there is space there. Okay, so you may find a rise in the beta HCG more than 63% in case of an ectopic pregnancy as well. So what will you do if there is a rise in by 63%? You will repeat her ultrasound. Whenever there is a good rise, you will repeat her ultrasound, maybe after a day or 14 days, depending on how low or how high the beta HCG was. You can repeat it earlier also before 7 days if the beta HCG value is now going more than 1500 because that is considered as a cutoff for you to diagnose the pregnancy on ultrasound. Okay, so just remember when there is a good rise in the beta HCG, you repeat the ultrasound to see what is going on, whether it is an intrauterine viable pregnancy or whether it is an ectopic pregnancy. Okay, so if it is a viable intrauterine pregnancy, routine care. If a viable intrauterine pregnancy is not confirmed, it is very much likely to be an ectopic pregnancy. So what do? You immediately refer her to a senior gynecologist. This is for a pregnancy of unknown location. Okay, so say the ultrasound is still inconclusive. You refer, but the rise is good of beta HCG. And you have now excluded the intrauterine pregnancy by doing a TVS, repeat TVS. You will refer to a clinical senior for a clinical review by a senior gynecologist. Okay, so this may be the bold thing that is highlighted, maybe one of the options. What will you do is refer to a senior gynecologist because it is rising very well and you cannot see. If it is plateau, it's not really a plateau, but it is not rising as high as 63%, but not falling as expected in a failed pregnancy. It is not falling by 50%. So it is falling by less than 50%. It's somewhere in the middle. That means it is not threatening to rupture as such immediately, but it is somewhere hovering in the middle zone. It is you cannot exclude an ectopic pregnancy. At the same time, you cannot really say for sure it is a failed pregnancy. So what you do is you ask for a clinical review in early pregnancy unit within 24 hours because it is somewhere in the middle. The first one was immediate referral because it has risen and you still cannot see a intrauterine pregnancy. That is very likely to be a ectopic pregnancy that is likely to grow and threaten to rupture. So that is why immediate referral. The second one, clinical review in early pregnancy assessment within 24 hours. Okay, why am I highlighting these points? Because these questions, these points can be asked in EMQs and The options may be A, immediate referral, B, clinical review. So that is why. Okay. So if it is somewhere in the middle, not really this side, that side, you know that it is not threatening to rupture immediately, and you're not sure it is a failing pregnancy, you refer to within 24 hours for early pregnancy unit. If it is falling more than 50%, okay, here it is unlikely to be a viable pregnancy because it is falling. So what do you do? Since it's falling anyway, you do a pregnancy test in 14 days. Okay, this is for pregnancy of unknown location. You do a pregnancy test in 14 days. And if it is negative, nothing more needs to be done. If it is positive, but remember it was falling, right? Again, you are a little relaxed because it was falling and it's not threatening to rupture, but it is still positive. That means there's something going on. So in that case, you refer to early pregnancy assessment in 24 hours. So the only place where you refer to a senior gynecologist immediately is when it is rising more than 63% and it is rising more than 63% and you cannot see an intrauterine pregnancy. All right, clear? All right, okay. We'll do the little bit about management of
I have one down.
uh
Ma'am,
yeah,
in
yeah, tell me.
the first row, it is mentioned that earlier if the value is more than 1500. So, ma'am,
Yeah.
the value has to be more than 1500, or it can be any value, and the rise is more than 63% according to those two values.
63%, see, for example, say today it is, the value was 500, okay? And after 48 hours, the value has become 1500. Now it has risen by 75%, right? 500, 500, 500. It has risen 3 times, okay? So, no, it is risen more than that. I mean, the percentage rise is much more. Okay. So, in that case, now it has already reached 1500. You want to know what is happening inside because 1500 is the level at which you expect to see a pregnancy, isn't it? So, and it is risen that high, that rapidly, likely to be an intrauterine pregnancy. So why will you wait for another 7 days? You will just do an RTVS and finish it off at that go because it is already risen to that higher level.
Ma'am, if the
Understood?
beta CJ is 50 and then it becomes 150, then,
Then that is
ma'am,
not at 150, you will not see a pregnancy, right? You will
yeah,
not see. That is why they are saying you wait for 7 to 14 days. No,
okay.
right? So 150 and 150 is not even a,
I
mm,
mean,
uh,
like it has
it's
to
not even
cross
a viable some.
1500. Otherwise, we'll just wait.
Yeah, yeah, yeah. Because before 1500, you do not see anything in the TV in the on the TVS doesn't mean anything because it could just be that it is too small. The pregnancy is too small for you to see. That is why the cutoff is considered 1500, isn't it?
Okay, ma'am.
Right. So you need to be aware that the cutoff for beta HCG above which you usually see a pregnancy is 1000 to 1. It's now even said it's 1000. The newer guidelines and newer even the strategy says 1000. Okay, so it is lesser now because the our transvaginal ultrasound machines are have very high resolution, which is why it is seen even
1000.
at a lesser level. Okay, right? And think,
The
yeah,
new
you were
value
saying
is
something?
1000, ma'am.
Hmm. Hmm.
New value is 1000, is it? According to the guideline.
Yeah, 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 yeah. The new value is 1000.
Okay.
Yeah, so it is 1000 to 1500. Depends on your sonologist, it depends on your ultrasound, it depends on many other things. Whether a trainee is doing the ultrasound, whether somebody senior is doing the ultrasound, what type of ultrasound machine. So you cannot say that at 1499 I will not be able to see, at 1500 I will be able to see. So basically it's a range. So around 1000 to 1500 is a value where you usually see the first sign of pregnancy, usually. Okay. And here it is said that above 1500, you will do an ultrasound earlier, because above 1500, with that much rise, more than 63% rise, it is very likely to be a pregnancy that would be seen, right? Because above 1500, usually it is seen. Okay. So that is why it is mentioned that if your 48 hours value reaches 1000, because after 48 hours you're not doing another value after another 48 hours, right? You're just doing, if it is rising by a good amount, you're just doing a TBS to check. Okay, so if it is as you said earlier, it was 50, now it is becoming 150. It's too small or too less a beta HCG for you to see anything on ultrasound. Okay, it may not be a definite, pregnancy as such. Okay, so it's too small a value. So in that case, you wait for at least 7 days or 14 days. Depending, if it is a lesser value, you can wait longer. If it is a bigger value, slightly more, like say 600, 700, 900, you wait maybe 7 days. Okay, if it is very smaller value, you wait for 14 days. That is how it is, because beta HCG will tell you how early the pregnancy is, can tell you, not always, but can tell you how early the pregnancy is, right? So that is how it is. Okay, clear? All right. So let's move on to the management. Now, management is important of miscarriage. I think after that we can cover the rest, maybe some other day, because it's otherwise it will be too long a session. So we will finish the management of miscarriage and then we'll wind up. Okay. So management of miscarriage is basically, there are certain important things that you need. Again, we'll just look at the charts, because if you just remember these, that is good enough for you to answer your questions. Now, if there is a confirmed diagnosis of miscarriage, now confirmed is when we have done those 2 scans, right? TBS is done, showing CRL less than 7. We have repeated, still CRL less than 7, no heartbeat. It's a miscarriage. So that is a confirmed diagnosis of miscarriage. So what do you do if it's a confirmed diagnosis of miscarriage? How many options do you have to manage miscarriage? Yeah.
Expectant, medical, and surgical.
Yes. So expectant, medical, and surgical. Expectant, you don't do anything. You in medical, you give them mifepristone, misoprostol. In surgical, you do an evacuation. So which one will you choose? First thing that you need to ask yourself is, now this is the way you have to think in the question. The question may be a clinical situation that is given to you. So you need to ask, is the woman at increased risk of hemorrhage? Is she late first trimester? Okay. Late first trimester would have an increased risk of bleeding, obviously, because she's in the late first trimester. Any previous adverse or traumatic experience associated with pregnancy? Okay. Is she at increased risk from the effects of hemorrhage? Like, is she having coagulation disorder? And the last thing, any evidence of infection? Okay. So what you do is you ask these questions. Okay. Now, if the answer to these questions is a no, first let's see this. You will choose expectant as the first choice. That means if she's in early pregnancy, late first trimester is like around 9 to 12 weeks would be your late first trimester. Say she's in early pregnancy, okay, like 6 weeks, okay. She has not had a previous or traumatic experience. So because waiting with the miscarriage, if she's had a previous traumatic experience, in the sense she's had many miscarriages in the past, she's sad about it. Waiting with another miscarriage can put her mental health at risk. That is what it is. The second point. Okay. Any previous traumatic experience that she has no traumatic. This is the first time. Is she at increased risk of coagulation? Is she a case of, say, von Willebrand disease? No. Does she have an active infection down there? No. If answers to all these questions is a no, you wait for expectant management. First choice. However, if any of these questions is a yes, you explore other options. Like if there is infection, you have to expedite the process. If there is a risk of hemorrhage, she can, with expectant, what can happen? She can bleed over a period of time, little, and with the coagulopathy, it can just result in massive bleeding. So that is why you don't wait. You just get the pregnancy out. A late first trimester, again, the risk of bleeding is more. So you get the pregnancy out. Okay. So, and any previous traumatic experience? She can, if you just keep the pregnancy, her mental health can worsen. So better to get the pregnancy out. Okay. So those conditions you explore other options, but otherwise, remember, first choice is not medical. First choice is expectant. Okay. And what do you do if the expectant is not acceptable? Like they may not want to continue expectant management. Then you offer medical. Okay. This is how the flow would be. This is as per the NICE guidelines. Okay. Now, if the bleeding or pain has not started or there is ongoing bleeding after 7 to 14 days of observing. Now, 7 to 14 days is observing for expectant. What you do, you have observed her for 7 to 14 days. Okay. Say you can call your patient after 7 days, you can call your patient after 14 days. Again, it depends maybe on the gestation. They have not specified. If it is too early, you can wait maybe a little longer. If it is a little, say, around 7 weeks, 8 weeks, you can call her earlier because otherwise she can just keep bleeding. Okay. But if nothing has happened, then what you'll do is you would do an ultrasound to check whether the process has not begun or it is incomplete or whatever. Okay. Now, if it has not begun, now you have to redecide what to do. You can discuss with the patient. Do you want to wait longer? Do you want to do your medical management and get it off, or a surgical management and get it off? Okay. So after 7 to 14 days, nothing has happened. You do an ultrasound to check what is going on in the uterus. And if, depending on what you find in the uterus, you discuss with the patient. Okay, so that is how it is. Then, and if she wants to have expectant continued, then you would ask her to come back after 14 days, more days. Okay, so what you're doing is after she has chosen the expectant in the first go, you first call her after 7 to 14 days. You evaluate if it has begun, not begun, do an ultrasound and check what is happening in the uterus. You discuss with her what she wants to do. She wants to wait, you call her after another 14 days. Okay, so that is how you will work this thing out. Okay, and if the resolution of bleeding and pain has happened in 7 to 14 days, it would indicate a complete miscarriage. So what happens is first 14 days you have called her after the first decision. You have done an ultrasound, you have checked her, you have decided to wait another 14 days, so 28 days. Okay, and now if you have noticed that there was bleeding and it has now stopped, the cramping has stopped, it may mean that it is complete miscarriage. So here you will not do a ultrasound because the bleeding has stopped or the cramping has stopped. Here you will just ask her to come back with the pregnancy test after 3 weeks. Okay, because after 3 weeks of a miscarriage that is considered complete, pregnancy test usually comes negative. If it is still positive, then you may have to work up, as in you may have to do a scan to check if it's the pregnancy products are still there. You may also have to consider molar pregnancy as one of the differentials. Okay, so all those questions would come to your mind. Okay, so what I'm trying to say is basically after expected management, you first call after around 7 to 14 days, review the situation. She wants to wait longer, call her after another 14 days. And in this time, if she has bled and it appears as complete, then you ask her to come back at 3 weeks. for a pregnancy test, or just ask her not to come back, do a pregnancy test after 3 weeks. If it is positive, come back. Okay, clear? Is that clear, everyone? Hello?
Yes, ma'am, it's clear.
Okay.
Yeah.
Now, as far as medical management is concerned, for miscarriage, we have the new drug. I mean, the drug which was not introduced in the NICE guidelines earlier. Now it is mentioned for miscarriage as well, not just for abortion. Okay, the missed miscarriage can be managed with 200 milligram oral mifepristone, followed by 800 microgram misoprostol, vaginal, oral, or sublingual. 48 hours later, unless the gestational sac has already passed. Okay, so you give today, you give 200 milligram. Once you have diagnosed and sure, and now she chooses, say, medical management, you would give 200 today, and after 48 hours, you would give 800 microgram. Okay, if it is incomplete, okay, if it is incomplete, you would give 600 microgram vaginal, oral, or sublingual. 800 microgram can also be used, but you don't give mifepristone. Okay, so mifepristone is used only for missed miscarriage. So if that's an option, you choose that for missed miscarriage, not for incomplete. Incomplete is when she's bleeding, partly the products are expelled and some of the products are inside. Os, on examination, the cervical os would be open. Okay, so that is an incomplete miscarriage.
Ma'am, in
Or even if
miscarriage,
the, yeah,
miscarriage, it is written that 48 hours later, unless the gestational sac has already passed.
passed.
So,
Yeah, because
like,
that can
how
happen
long
with
we have
the
to give?
mifepristone itself. Right?
How long do we have to give misoprostol 800?
No, you give it
Is it
after
that
48
dose
hours.
or yeah? So, like, if even after that it does not, it does not pass through the cervical canal. I mean,
It
there
does
there
not
is,
miscarry.
yeah, there's a something retained. So, like, how long do we need to repeat it according to this guideline, or we just do the surgical management?
You mean to say after the second dose?
Yes, ma'am. After 48 hours, we have given 800
Yeah.
misoprostol. Still, nothing has happened. Then what do we do?
Yeah. So after that, you can review whether you would give how many doses later is not clearly mentioned. Whether you can give another 5 doses or 6 doses or another single dose is not clearly mentioned in the guideline.
Do we give the dose, or we go for surgical management since it has
No,
failed?
it's not mentioned. It's not mentioned. So it is not. It is. I cannot say tell you that if you do medical, it will be right after the second dose. And at the same time, I cannot really tell you that no, you have to do surgical. It's not given in the guideline. Okay, you have to review the situation with her. You have to give her the options later, both whether she has to receive another, because for abortion there is
Okay.
termination of pregnancy. The guideline mentions that you can give further doses of misoprostol. Correct. So it's the same thing actually, technically. Right. Here also you should, if you can give there, you can give here as well, right? So, but it is not clearly mentioned that if this is the case, then this is what you need to do. Okay. So, yes, if there is ideally, like this would be a part 3 exam situation. Okay. Ideally, you would counsel the patient. You'll give her the option of continuing misoprostol at specific intervals, but that is not mentioned clearly. Okay. And and the option of surgery. So at every step, you have to review with the patient, technically, ideally. Okay, so it is not said that if after 48 hours of misoprostol, when you give misoprostol, it is still not complete, you will go for surgery as the next line.
And ma'am,
Okay,
one more question related to this one
yeah.
only. If the weeks of gestation it differs, like,
Mm.
for first 12 weeks and later 12 to 20 weeks? Is the value
Yeah.
same for all the, I mean, even if it's late trimester or something like that, or is it like a lesser dose of misoprostol?
Though that would be your in what sense exactly are you asking? First trimester or what exactly are you asking?
If it is, ma'am, like one pregnancy is 8 weeks, another pregnancy is 16 weeks. So,
Hmm.
ma'am, those will be same if it is miscarriage.
Actually, there are doses. Wait 1 minute. I'll show you that as well. Give me a moment. There are various doses,
Madam, in
and if you
miscarriages, the doses are same only. In MTP, the doses are different.
correct. Yes, that's what I'm saying. That's what I was showing you. That there is a nice guideline. Wait, let me check the doses.
And in this case,
But
madam, the patient doesn't bleed or the pregnancy test is negative after 3 weeks, we have to give the option of surgical, medical, and expectant again. And
yeah,
after the
yeah.
patient go for whatever management she wants, we can provide her that only.
That's right. That's right. That is what I'm saying. That you have to at every step you have to review. You cannot say that if the medical method fails, the next step would be surgery. No, you have to give her the option. And like as you mentioned about, let me show you about this. This was the, sorry, this is the, let me show you this slide. Okay. Like if you can see, see, here also, what is mentioned is this is for now, this is the guideline for abortion. Okay, for women who are having a medical abortion between 10 weeks and 23 weeks, 6 days. Okay, and who have taken 200 milligram mifepristone, offer an initial dose 36 to 48 hours after the mifepristone of here. Same it is, say 800 microgram misoprostol given vaginally, and you will offer 600 microgram misoprostol given sublingually. So even for a termination of pregnancy, the dose is same. So it technically for your missed miscarriage, the dose should be same. Okay, and this is what I was telling you earlier that for termination of pregnancy, they have mentioned about you can give 400 microgram doses of misoprostol every 3 hours until expulsion. There is no cap of the upper limit.
So, ma'am, we are terminating only, no, miscarriage. We are terminating the pregnancy, no, because there's no heartbeat. So we can give 400 every 3 hourly until expulsion.
Uh, this is for termination, dear. Termination of pregnancy is different from miscarriage. You can give, but it is not mentioned in the guideline. You can do anything for that matter. What I'm telling you is it is not mentioned in the guideline. What is the next step? The next step would always be talk to the patient. Talk to the patient whether she wants to continue medical management. You can give this 400 microgram dose of misoprostol every 3 hours. Okay? Or you can do a surgery. Okay? That's the thing.
Medical
As
termination
far
of
as the,
pregnancy is only when the fetal heartbeat is present. Is it?
yeah, yeah. When I'm saying termination of pregnancy, it is an abortion, an abortion which is done when for other indications, anomalous baby or Down syndrome or mother is having some problem, then that is termination. That is called termination, MTP, like we call in India, right? So there it is called termination of pregnancy. Okay, what I'm trying to tell you is there is no guideline to continue doses for missed abortion, for missed miscarriage. There are, on the other hand, for your medical termination of pregnancy, you will say that you can give by as per guidelines. You are protected by guidelines. As per guideline, you are going to tell her that you can give 400 microgram till expulsion every 3 hours. It is not. It uh, it is not so that you cannot do it in miscarriage. What I'm trying to tell you, it is not given in the guideline. Okay, so that these two things are different. Got it? So since it is not given in the guideline, you can always give her the option of that way. Even in a termination of pregnancy, you can always give her the option of surgical. But you are protected if you give 400 microgram every 3 hours because it is mentioned in the guideline. That is how it is. Why are guidelines there? Because it gives you a way to, it gives you a kind of a support system to support your management of a patient. All right. But it is not true to say that you are wrong if you continue misoprostol after giving initial 800 microgram. That is not true.
Okay,
You
ma'am.
can give. Okay, but it is not mentioned in the guideline. So when it is not mentioned in the guideline, what are you going to do? You're going to give her the option of both, right? So either this or that. Again, you have to assess the clinical situation. If it is given to you that now she's bleeding heavily, you will have to go to a surgical way of evacuating the products, right? So that is how it is. Okay, so now, yeah, so basically after medical management, you have to do a urine pregnancy test 3 weeks after you think the procedure is complete. Okay, so the mm, uh, pregnancy test comes negative, nothing more needs to be done. But if she has bleeding or she has persistent complaints like pain, etc., you may need to do a few further investigations. Okay, so basically, just in like in expectant, in medical also, you will do her pregnancy test after 3 weeks. And after 3 weeks, pregnancy test ideally has to be negative and she should not have any symptoms. Okay, so that should be the end of follow-up. All right. Then the surgical management is either your manual vacuum aspiration under local or surgical management in theater under general anesthesia. Okay. Now this is a little confusing about NTD. Has anybody noticed what is the confusion? Yeah. As far as NTD is concerned, the guidelines are contradictory. Okay, so as far as NTD is concerned, the older guideline or the the NICE guidelines, the recent one, 2020 NICE guideline, would say that if she's less than equal to 10 weeks, do not give NTD. Yeah, and RCOG or the BCSH guidelines would say that you would give NTD for medical abortion. Okay, so now this is the confusion.
So, ma'am,
But
will give more
the
weightage to nice.
sorry.
Will give more weightage to nice if the confusion is there.
No, not so as of today, because the reason is this. If you go to the Green Top guideline section, it will direct you to the same NTD guideline even today. Okay. Even today, if you go to the RCOG website, it takes you to that guideline, the NTD guideline, BCSH guideline. Okay. That means it is still valid. Okay, so when you have a conflict between a GTG and a NICE guideline, you would give a preference to the GTG, provided it is not mentioned on the RCOG website that the guideline is archived and refer to NICE. Got it? If the guideline is archived and you have to refer to NICE, then you refer to NICE. But otherwise, you follow what is given on the RCOG website. Okay, and another reason why I would say I would recommend that you follow that is because when you're giving something that could potentially result, like in this case, NTD is being given for medical abortion. We all know that medical abortion could potentially result in fetal-maternal also immunization, basically. You're giving NTD, and RCOG says give NTD. So not giving NTD is like withholding the treatment. NICE says it's based on studies that have shown that it doesn't really cause any harm, not giving NTD. That is why they are saying do not give NTD. Okay, all these guidelines are based on studies. Remember that. Evidence. Okay, so that is why NICE is saying that. But at the same time, your RCOG still refers to BCSH guidelines. So refer to the BCHS guidelines as far as this particular thing is concerned. You can mention give. Okay. Less than 10 weeks, surgical abortion, NICE guidelines and the RCOG 2011 is almost the same. RCOG says give. NICE guidelines would say consider. And more than 10 weeks, medical, surgical, both NTD as per both the guidelines. Okay. As far as RCOG 2011 is concerned, they say that if there is a spontaneous miscarriage, and this is what is to be followed, uterus is not instrumented where the pain is mild and it is less than 12 weeks. So it's like a spontaneous miscarriage, which is mild, paining just mildly, and the uterus has not been instrumented. You can withhold NTD. Okay, clear? This is as per the old guideline itself. Okay, so this is actually the only place where you withhold NTD, right? Now, so from exam point of view, just follow the PCHH guidelines. NTD. Again, NTD is they've mentioned is that a minimum dose of 250 international units NTD should be administered to all cases of ectopic pregnancy in previously non-sensitized D negative women, regardless of the mode of management. This is your BCSH or the RCOG guideline, right? But what NICE mentions, give for surgically managed ectopic pregnancies only. This is what NICE guidelines mention. Now, what to support? Again, I would say go with RCOG because NICE guidelines mention that there is lack of supporting evidence. Okay, there is no evidence to support. All right, so that is why go with this. Okay, is that clear? Any questions so far on any of the topics that we covered today? I think we can wind up with
Ma'am,
this. Yes.
there are different doses of NTD given according to the different week of gestation. Ma'am, can't explain that as well.
Yeah, it is 250 international units that you would give in less than 20 weeks of gestation, right? And more than 20 weeks would be 500. So anything that is less than 20 weeks would be 250. Okay, and more than 20 weeks, you also have to do your KB test. And if you by KB test you think that the fetal hemorrhage has occurred more than what can be neutralized by 500 international units of NTD, then you would need to give more. Okay, 1 ml is neutralized by 125 international units of NTD.
Okay, ma'am.
Okay,
Thank you.
yeah. All right. So, any questions any on this part so far? Okay, then we can wind up this session. Thank you for your patient listening. And if there are any questions, you could always ask on the group. All right. Thank you.